So I was asked to participate in a multidisciplinary panel discussion about multimodality care for cancer patients. And one of the platforms that we use to study different approaches to what's called multimodality therapy is using a neoadjuvant platform. Generally speaking, over the years, the use of combination therapies that would include either chemotherapy or more recently with immunotherapy is used either before or after surgery in patients who have kind of early to mid-stage disease that are newly diagnosed, and where surgery would be the main component of their treatment. And historically, what would happen is that patients would have surgery first, and then patients would receive additional therapies systemically that would hopefully treat widely disseminated disease at the microscopic level. So there's a lot of patients who presumed to be curable with surgery alone, but are at high risk of having to develop distant disease at a later time. And the source of that distant disease is usually microscopic disease that's already disseminated at the time of the diagnosis. So patients can receive systemic therapy, and historically that's been chemotherapy to help prevent the development of clinically apparent disease at different sites like the lung, the liver, the brain, and whatever. And patients that are identified as being high risk for developing that disease based on certain pathologic features within the tumor, as an example, would receive this additional therapy, and that was called adjuvant therapy. So the definition of adjuvant is to treat the presumed presence of microscopic disease elsewhere. And historically, that therapy has been given after surgery. But the problem with that, if you wait to give it after the surgery, the patients might already develop clinically apparent disease while they're healing up from the surgery, as an example. So another option or another model is to start with the systemic therapy to try to treat the microscopic disease up front that we presume is present, and then do surgery. And so that model is called a neoadjuvant model. So the adjuvant therapy is given first, and then the surgery is given second. And then in some situations, depending on the response to therapy within the tumor that's actually removed after the patient receives the neoadjuvant therapy, patients can receive additional therapies afterwards to try to consolidate the response. And that would be called a perioperative approach. So there's actually three models in which to use combination therapy in patients that are eligible to receive surgery with what we call curative intent. So the three models are: they could have surgery first, and then they can receive the adjuvant therapy after surgery. There's another model where they receive the systemic therapy or the adjuvant therapy first, and then they have surgery. And then the third model is like a sandwich. They get the adjuvant therapy first, then surgery, and then depending on the response to that therapy, looking at the tumor under the microscope after it's been removed surgically, they can receive additional therapy afterwards, and that would be the another adjuvant phase. And that therapy could either be the same as the therapy that was used to begin with, or it can be altered depending on the response. And historically, this model of giving the therapy up front has been used primarily with chemotherapy. But since that time, there's been the development of immunotherapy that are called checkpoint blocking agents, and that's usually anti-PD-1 or something called anti-CTLA-4, which is ipilimumab. So either single agent PD-1 or combinations with anti-CTLA-4 or ipilimumab has now been proven to be effective in many solid tumors. Initially at the stage 4 settings, where patients have widespread disease. And now these therapies have been moved into the earlier stage of disease, mostly in the resectable stage 3 patients or the patients that have high-risk primary tumors. And the immunotherapy has been very effective now across a broad range of solid tumors. And it's been studied now in breast cancer, lung cancer, some of the urologic cancers, now colon cancer, and probably the most important disease that was treated with immunotherapy was and has been is the advanced patients with melanoma. And so there was a really important kind of change or transformation, which is why the title of the presentation was called the neoadjuvant revolution. And in reality, the neoadjuvant strategy wasn't really the revolution. The revolution was really to use immunotherapy within that platform, because it was shown that unlike chemotherapy, which works at the level of the tumor, immunotherapy works at the level of the body's immune system, that the immunotherapy can help the body identify tumor antigens that are thought to be foreign, and then the body makes killer T cells against those antigens, and those T cells are kind of expanded, and they then disseminate throughout the body and identify tumor cells that are thought to be foreign, and the body attacks them and kills them using these T cells that are activated by this immune system. So it's been proven that immunotherapy works after surgery, but it actually works better if you give it first. Unlike chemotherapy, it doesn't really make a difference if you give the chemotherapy first or second, that its effectiveness is probably the same. But if you give the immunotherapy up front, it seems to prime the immune system, because there's all this tumor antigens that are intact because the tumor is still there. But if you remove the tumor first and then give immunotherapy, there aren't as many antigens around to kind of prime the immune system. So even though it is still somewhat effective after surgery, it's more effective if you give it before the surgery and actually give it after the surgery, because it primes the immune system so that the therapy given after surgery then works better. So the first trial that actually compared a perioperative approach of neoadjuvant versus a adjuvant approach. So the adjuvant approach would be the post-op, for example. So the standard of care in melanoma was to do surgery first for patients who have stage 3 disease and then give the immunotherapy. And that was proven to be better than just surgery alone. But this trial then compared that standard of care versus giving the immunotherapy up front, having the surgery, and then giving it afterwards. So the kind of post-operative adjuvant strategy versus the perioperative strategy. Understand? Yeah. And that data was remarkable, showing that those patients who received the neoadjuvant strategy did much better than the patients who had just the immunotherapy after surgery. So that kind of led to a revolution where other tumor types that were found to have good favorable outcomes by giving immunotherapy, either as single agent or in combination with anti-CTLA-4, that same paradigm of perioperative neoadjuvant therapy was then tested in multiple other cancers: lung cancer, breast cancer, bladder cancer, head and neck cancer. So now there's at least 5 or 6 tumor types proven to have a beneficial effect when the immunotherapy is given in this kind of neoadjuvant platform. Okay. And so moving forward, I mean, we still have a lot of work to do, because even though the patients who receive immunotherapy in this setting, still a lot of patients end up relapsing and dying from their disease, even though they're doing better than the patients who just received the therapy in the adjuvant setting after surgery. So, But this model really allows us to do really important smaller trials where we try to add therapies in the preoperative setting to try to improve the response rates that we identify after the tumor is removed. So in these trials of neoadjuvant therapy, studies show that the extent of the response of the pathologic response predicts outcome. So the more likely or the more extensive pathologic response, like for example, if the tumor is completely dead, that's called a complete pathologic response. In that setting, the patients do really well after surgery. So the better the pathologic response, the better the patients do. So right now, the emphasis is on trying to improve the complete pathologic response rate. Like, for example, in melanoma, one of the studies showed that if you use combination immunotherapy, so the combination of the single agent PD-1 with anti-CTLA-4, that combination resulted in a close to a 70% complete pathologic response rate, compared to single agent, which was about 53%. So there's efforts to try to improve that complete pathologic response rate because we think that would translate into better outcomes. And maybe even reduce the need for therapy after surgery. Like, for example, for the patients who experienced a complete pathologic response, studies are now showing that they may not even need the additional therapy after surgery, that the 2 or 3 cycles up front may be enough. So in addition to showing improved outcomes, we may be able to limit some of the toxicity of our therapies, both physical toxicity related to side effects, but also financial toxicity, right? These drugs are expensive. So the neoadjuvant platform is like the best way to study strategies to improve the complete pathologic response rate. And some of those studies are what's called window of opportunity trials, where you have a small number of patients where you're adding another agent to the framework of either the single agent immunotherapy or the combination immunotherapy, and to see if you can increase the response rate. You don't need a lot of patients to actually study that. And the other important thing about this model of a neoadjuvant platform is that you can study surrogates for response or resistance to the therapy because you have access to the tumor, so you could do biopsies at the level of the tumor before therapy. You can do biopsies during therapy, and then you have the whole tumor to examine after the surgery. Yeah. And in addition, you can do certain blood tests to test for what are called surrogate markers for response or resistance. Something called circulating tumor DNA, for example, is another way to monitor for response. So combinations of the extent of pathologic response, as well as some of these other circulating markers, can help us create a model where we can predict if patients are going to recur or not. And if the prediction is that they're not, they probably don't need any more additional therapy after the surgery. And so this is the model kind of moving forward now that's really been validated, where we can really study all these different aspects of multimodality therapy in patients who have potentially curable and resectable disease surgically. So that's really what the entire talk was about these mechanisms of response of therapy given after surgery versus therapy given before surgery and after surgery, and which led to a panel discussion with 3 other physicians in a different that were studying different tumor types. Like my clinical interests, I treat melanoma. I treat advanced melanoma. So there was a physician who was a gastroenterologist because there's data related to colon cancer with immunotherapy. There was a urologist on the panel because of the data related to improvements in outcomes with bladder cancer with immunotherapy. And the third physician was a physician who's a thoracic medical oncologist treating lung cancer. So in these 4 sites of disease, at least, this model has shown very favorable outcomes when using immunotherapy. So really the revolution was the use of immunotherapy therapy within this kind of multimodality model per se. That allows us to do biomarker discovery. It's just a very facilitating way to move cancer research forward. It's also a way to test new. It's also a way to test new agents, new combinations, and could potentially lead to trials that would be registration trials where the FDA would actually approve these combinations.